So I think you can see the various causes of allergens which are causing allergic rhinitis and urticaria, that is plants, animal proteins, pollens, various kind of synthetic items like latex, rubber, gloves. Also bee sting and medications may also cause allergic reactions, severe allergic reactions in a person. Similarly, rhinosinusitis or allergic rhinitis, mostly dust mite, that is Demodex follicularum, pollen grains of various flowers, and very importantly, some drugs may also cause various kind of allergic reactions. Now, allergic reactions can be divided into depending upon the systemic manifestations. So most importantly in the skin, it is rashes or urticaria or hives, and also sometimes allergic contact dermatitis with it, that is reddish reactions to some foreign allergens can be seen, and dermographism is also one of the type of urticaria. Other types of allergy reactions in our body includes rhinitis, that is inflammation of the nasal mucosa, that is nasal mucositis, runny nose, that is known as rhinorrhea, and sneezing. Apart from it, allergic sinusitis is also very commonly seen with pollens and dusts. In the eyes, there will be presence of redness, itching, and burning sensation of the conjunctiva, known as allergic conjunctivitis, one of the most common conditions seen day-to-day settings. That is, patient is presenting with allergic contact dermatitis or allergic conjunctivitis due to various allergens. And in bronchitis or bronchoalveolitis, cause of bronchoconstriction, wheeze, and sometimes exacerbation of attacks asthma can be due to similar kind of allergens, basically due to activation of the histamine pathway. And gastrointestinal pathway, abdominal pain, bloating, vomiting, and diarrhea. This is often underlooked symptoms, but many a times, specifically in patients suffering with mast cell tumors like Langerhans cell histiocytosis and cutaneous mastocytosis, and sometimes ingestion of contact allergens. It may give rise to severe abdominal pain, specifically patients who are taking allergic to seafood and consume it by accident. So they develop this kind of symptoms, that is abdominal pain, bloating, vomiting, and diarrhea. So going to the basic pathophysiology, how these symptoms are developing. The main culprit is mast cell, and mast cell contains, as we all know, that is histamine. Apart from histamine, 5-hydroxytryptamine and other chemical mediators are there. Whenever mast cell is activated due to attachment of some kind of allergen, they release major allergic inflammatory mediators, that are histamine, 5-hydroxytryptamine, and other mediators are there that are released in the blood circulation. As these agents are released in body, they are basically causing a severe immune response. Now these allergens, they have various specific receptors present over our body. Now various histamine receptors are, I think you have in your pharmacology and physiology classes. First is the H1 receptor. So H1 receptor is present throughout the body, over the nasal mucosa, smooth muscles, blood vessel, heart, and CNS, and they cause allergic reaction. And they are specifically inhibited by H1 antihistaminics. So mostly on the cutaneous surface, they are present over the nasal mucosa, smooth muscles, blood vessels. So all kind of symptoms will be there. H2 receptors basically present in the parietal cells. They are responsible for acid secretion. H3 receptors, CNS, and basically for cognitive symptoms. And H4 receptors, autoimmunities. So this is not important. Now most important things are H1 and H3 receptors. Now non-selective with antihistaminics, they will block all kind of these receptors. So in low doses, most affected are the H1 receptor and the H3 receptor. Now non-selective antihistaminic will go into the brain, will act through H3 receptors, causing sleep and cognitive issues. So how the mechanism of allergy is basically happening. This is a pollen. It is giving rise to the allergen attaching to the IgE-Fc receptor. Now IgE-Fc receptor is basically attachment of IgE antibody. So this is B cell which is presenting IgE. The Fc receptor here it is attaching the pollen antigen, and IgE antibody is produced. Now this IgE antibody will go and attach to the mast cell. So prior sensitization is required to produce a profound response. Whenever you eat seafood on the first time, you will not get a response. But after repeated exposure to seafood or repeated exposure to the specific pollen or plant or chemical or anything, then you will have adequate amount of IgE antibody, which will go and attach to the mast cell. After attaching to the mast cell, there will be what? A prepared response mechanism. So this IgE antibody is attached to mast cell. Now the mast cell is able to recognize the antigen whenever some attack of antigen is there. Now this antigen is attaching to the IgE antibodies through the Fc receptor. Okay, here Fc receptor. So cross-linking, when cross-linking is happening, it is activating a memory response, giving rise to degranulation of the mast cell, giving rise to primary and secondary mediators. So this will give rise to various kind of allergic reactions, including asthma, hay fever, urticaria, and anaphylaxis. So second response is the most important response which we are concerned about. Now complete pathway, again same degranulation and releasing of mast cells, antibodies are released, then again cross-linking of the antibodies is happening after attachment of antigen and immune responses. Now types of allergic diseases, most important is allergic rhinitis, then urticaria. Apart from it, pruritus, contact allergy, and food allergy are also important in these cases. So urticaria is basically nothing but is a vascular reaction of the skin characterized by wheals. So wheals are what we call as transient, evanescent, erythematous, raised skin lesions with perilesional erythema and severe itching. Okay, so real etiology of urticaria is unknown. Basically, it is supposed to be one of the, that is triple response, Lewis triple response, flash, flare, wheel. So it is one of supposed to be component of Lewis triple response and supposed to be local vasoactive amines, that is histamine or 5-hydroxytryptamine. When local vasoactive amines are released, this urticarial rash is happening. Now urticaria, the dermal edema and the swelling and itching is seen in cases of urticaria. It can be divided into two parts, that is spontaneous urticaria, that is less than 6 weeks, and chronic spontaneous, that the duration is more than 6 weeks. So most importantly, we are now concerned about chronic spontaneous, because as we know, sometimes spontaneous urticaria day to day, some or other you will be experiencing, and it usually resolves in its own. Whereas in cases of chronic spontaneous urticaria, the disease is not resolving because of the hyperimmune response or repeated antigen exposure, or both or none, maybe some autoimmune reaction, we don't know. So we are mostly importantly characterized by chronic spontaneous urticaria. Now symptoms of urticaria: raised wheals, redness, itching, and rash that is have a blanching. So it is a transient lesion. It may blanch when you compress it. So treatment options: European Academy guidelines and EDF guidelines and World Association of Urticaria guidelines. So first drug to consider is antihistaminics, that is second generation antihistamine. So we used to use Cetirizine and we used to use Cetirizine as the first line therapy in cases of chronic urticaria. Now, if the disease is not self-resolving, we will add systemic steroids. Still, if the disease is not resolving, immunosuppressant like cyclosporin is used in these conditions. Now, treatment algorithm, we need not to go in other conditions, like in conditions, we have to give some kind of antihistaminics to control the feeling of itching. Now, pruritus can be associated with systemic diseases also. Some conditions like cholestatic liver disease, like biliary or obstructive jaundice, because bilirubin is supposed to be one of the chief irritants in our skin. When an excessive bilirubin is present in our skin, patient suffers with severe itching. Similar to that condition, in cases of chronic renal failure, accumulation of creatinine, that also causes, leading to endogenous ophthalmic disbalance and mast cell activation. That may also causes severe itching in the patients. Apart from it, in cases of diabetic neuropathy, hyperthyroidism, and many neoplasms, specifically mast cell neoplasms. Okay, so there will be excessive release of histamine and excessive histamine degranulation leading to itching. So antihistaminics, first generation, second generation. So first generation antihistaminics had a sedative activity. So in the first generation, chlorpheniramine maleate, estimazole, terfenadine was developed, and they used to have a very good antihistaminic activity, but they had additional cholinergic activity and additional sedative effect. So to counteract those things, newer generation antihistaminics were developed with less sedation and with less cholinergic activity. So in the starting, cetirizine and loratadine was developed. Then afterwards, levocetirizine came. Levocetirizine is supposed to be a groundbreaking drug with very less side effects, very less drug interactions, with good allergic control and very good biosafety profile. Now, newer generation antihistaminics which are coming now are supposed to be even better than levocetirizine in various criteria which we will be seeing today. So this is difference between first generation and second generation antihistaminics: more crossing blood-brain barrier, less efficacy, less specificity, shorter duration of action. Newer generation antihistaminics, they are non-sedating, no anticholinergic activity, good efficacy and safety ratio, longer duration of action. So why second generation are preferred? Due to all these reasons. Now, Bilastine is a new second generation antihistaminic which is used in treatment of allergic rhinitis and urticaria, and it is highly selective H1 receptor antagonistic with negligible blood-brain barrier crossing. It doesn't cause any sedation, has a faster duration of action, and it has it's a longer T half compared to near second generation antihistaminics. So how it is acting, we know Bilastine acts by activation of H1 receptor. It is prevent the activation of H1 receptor and thereby reduces the development of allergic symptoms due to release of histamines. Basically, what happens here is the antihistaminic, that is Bilastine, which is acting to the H1 receptor. So whenever this receptor is blocked, activation of mast cell is not happening, leading to decrease in symptoms of urticaria and other allergic conditions. So most importantly, metabolism, it is not metabolized by P450, and high plasma protein binding gives rise to very good absorption and good safety profile. And the drug takes reactions within 1 hour. See, 1 to 1.5 hours, the drug reaches peak level in blood, giving rise to prompt relief of the symptom. And route of elimination mainly limited in feces and rest of the part in urine. So there is very little hepatic metabolism, giving rise to good safety profile of the drug. And most importantly, the half-life of drug is almost 15 hours. So due to this long half-life, what happens? This drug stays longer in the blood, giving a good biosafety profile and good complete coverage of the urticaria, because we all know urticaria is notoriously resistant and they keep on recurring after giving antihistaminics. So longer duration of action drugs has the advantage of a single dosage in a day, that is 20 mg in a day, and it will give patient relief for a longer duration rather than other neurogenerations antihistaminics. So here we can see how bilastine is binding to the crossing the blood-brain barriers. There is no, it is not crossing blood-brain barrier at all. So very less so regime. So once OD dosage is there, whereas in cases of other drugs, dosage twice daily dosage, like in cases of bapostatin, is there. Again, duration of action is 2 weeks, and duration of action is more in cases of bilastine, whereas in cases of loratadine, the T half-life is less. And the drug can be given in patients who are hepatic compromise, or in patients who are suffering with end-stage renal disease. Bilastine can be easily given and no adjustment is as such required. Whereas in cases of other drugs like Cetirizine, so dose titering has to be done to reduce the toxicity of the drug. So advantage of bilastine over cetirizine. What is the advantage? First is highly selective for H1 receptor. So it will not attach to other receptors. So it will decrease the side effects, that is sedation or anticholinergic effects will be reduced. Secondly, the half-life is quite long. So half-life is long, that's why the drug will stay in blood for longer duration. And thirdly, most important is it can be used in renal and hepatic transplant patients, because it doesn't affect the renal and hepatic profile. So again, we see that bilastine having a longer half-life, single OD dosage, high specificity for the reaction, less sedation, no cholinergic action, can be a preferred drug in cases of chronic urticaria or in cases of chronic allergic conditions. Here again the comparison with levocetirizine, again comparison with fexofenadine. So in cases of pediatric age group, there has not been a large-scale study and FDA approval is still not yet, but it has been seen that bilastine can be easily used in pediatric age group in reduced doses, that is 10 mg, because of its high safety profile, not crossing blood-brain barrier, and it is not affecting liver or kidney. So to summarize the condition, first we have to know that 30 to 40% of the population is suffering from some kind of allergic diseases, and newer generation antihistaminics are included in the first line management of these conditions, including bilastine as a good weapon against these conditions with high T half, very good safety profile, and no sedation can be an additive advantage. And it can be used in place of other lower older generation antihistaminics like chlorpheniramine or hydroxyzine, which is causing high sedation and other cholinergic signs and symptoms like dryness of mouth and dilatation of pupil and other things that. So again, bilastine, one more important thing is that in pregnancy, the category of bilastine is category B. So the drug is safe in conditions like pregnancy or prepartum or breastfeeding women. Okay. So how this is across the bilastine is used in across all spectrum of urticaria. So various studies which have been done. So it was a short talk basically regarding bilastine. Okay. So I think most of you have gone through classification of antihistaminics. Many times in your exams, they might ask you. Okay. And most importantly, I think you all have gone through the Excel file I have sent to you. Okay, you can find your results in that Excel file. Okay. So now today the time is little bit less. I think we have wasted a lot of time. Otherwise, I have we could have done through the question paper. We could have discussed the question paper. Still, we'll start with any queries are there regarding newer generation antihistaminics, or any queries regarding your question paper. If it is there, you can ask me. Okay, so I think we can discuss with some questions. Okay, so you can discuss with some few questions. First was the herpetic whitlow. Now, herpetic whitlow, many of the people have marked. I have seen many of you are marking what is herpes zoster, herpes simplex of herpetic whitlow is what I asked question. So many of you are marking what? Tip of the fingertip. Many were marking tip of the nose. So tip of the nose is basically what it is. What is tip of the nose? Can anyone answer? If the tip of the nose vesicles are present over the tip of the nose, the condition will be, that is Hutchinson sign, that is seen in herpes simplex. Sorry, herpes zoster. Okay, tip of finger will be herpetic whitlow. Okay, tip of finger will be herpetic whitlow. So it is caused by herpes simplex virus. Okay, whenever suppose you are having herpes simplex on the lips, you touch the finger there and you get infected on your fingertip. That is how herpetic whitlow is happening. So do remember herpetic whitlow seen in herpes simplex, whereas Hutchinson sign in herpes zoster. Now second question, which Kaposi is vericilliform eruption. Kaposi is vericilliform eruption, as we all know. Basically, it is caused by what? Seen in herpes simplex. Okay, so known as eczema herpeticum, basically seen in herpes simplex, and it is not caused by varicella zoster virus. It is caused by herpes simplex virus. Okay, so that is one of the things you have to remember. That is Kaposi's vericilliform reaction is basically caused by herpes simplex virus. Okay, not zoster virus. So this was one of the questions. So many of the people have put wrong answers. So do check and go. Now third question was Zhang smear. Now Zhang smear we have already discussed. Zhang smear is basically a bedside clinical examination. So two things are usually seen in Zhang smear, that is acantholysis and multinucleated giant cells, so ballooning giant cells. So acantholytic cells or ballistic keratinocytes and multinucleated giant cells. So acantholytic keratinocytes will be seen in blistering disorders like pemphigus vulgaris, pemphigus folicis, whereas multinucleated giant cells will be seen in viral disorders like herpes zoster and herpes simplex. So you should always, and viral inclusion will be seen in a cigar bundle appearance. Finger is bit low, whereas involvement of the tip of the nose is known as Hutchinson sign. Okay, Hutchinson sign says if the presence of involvement of the tip of the nose is there, definitely corneal involvement will be there, because both the nerves, tip of the nose and cornea are supplied by nasociliary branch of ophthalmic nerve. Okay, so Hutchinson sign is seen. Okay, so this is how we discuss about all these things. I think question time is less. We will discuss about the questions, few questions in the next class also. Any queries you have regarding the test papers? Have you all gone through the results? Okay, so we will slowly discuss all the questions in each and every classes, because without discussion there is no point of reading. You will not be able to remember the things. Again, you will forget. So go through your Excel sheets, okay, and just read all your questions what you have marked and which of is right or wrong, and assess yourself how you have performed in the test. Okay, I am keeping the test on for everyone. Everyone of you can log in and see the questions and see your responses. Okay, so that the test is not to judge somebody is good or right. The test is to judge yourself how you have studied and how you have fared in the exams. So I am keeping the test on for everyone, okay, so that everyone can go and see the questions and responses, and after that it's like you can always discuss with me and send questions. Here responses are there, you can see. So here you can see the responses. I'll discuss one by one. Okay, so herpetic whitlow, the question answer is herpes simplex or tip of the finger. So most of them you have done good. Then again, Kaposi is verifilliform caused all except varicella zoster virus. It is called by varicella simplex virus, herpes simplex virus. Then Zangsmeer multinucleated giant cells. So individual tip of the nose, if herpes zoster is involving, that sign is known as Hutchinson sign. So most of you have marked it right. So I think you have studied this question. Then Ramsay-Hunt syndrome. Now Ramsay-Hunt syndrome, I think you have discussed in your ENT classes. Now ipsilateral faciophalcy contralateral hemiparesis, it is not Ramsay-Hunt syndrome. Ramsay-Hunt syndrome will be triad of, what is that? Most commonly it is myoclonic epilepsy and all except, that is, so ipsilateral faciophalcy and contralateral hemiparesis will be seen in cases of what condition? You just read and let me know. So myoclonic epilepsy, progressive ataxia, triad of ipsilateral facial paresis, ear pain. So it will be on the same side. Contralateral hemiparesis, that means some vascular involvement is there. So it is not seen in Ramsay-Hunt syndrome. Okay. Now all are true about Koplik spot. So Koplik spot is basically seen in measles. So it is are exanthematous spots. So where it is seen Koplik spots inside mouth. So exanthem will be on the skin, enanthem will be inside the mouth. So it is a enanthematous spot, not exanthematous spot. So other conditions were right. So this is the wrong answer. It is an enanthematous spot, not exanthematous spot. Okay, you have question. No, no, not ulnar nerve. It is not ulnar nerve. Somebody is asking ulnar nerve involvement is there in cases of Ramsay-Hunt syndrome. Oh, where is the triad of facial paralysis? That is not ulnar nerve. See this neuropathy of deep palmar branch of ulnar nerve. This is basically happening in cases of Ramsay-Hunt syndrome when higher involvement is there. See, Ramsay-Hunt syndrome basically where it is happening, involvement of tympanic membrane, vestibulocochlear nerve. Now around the vestibulocochlear nerve, where it is affecting the vestibulocochlear nerve involvement and going into the which canal it goes through vestibulocochlear nerve, inner canal in the cranial cavity. From that canal itself, the nerve roots of the cranial nerve roots are traveling. So sometimes the swelling of the nerves will lead to compression of the swelling of the nerve will lead to compression of the nerves in the canal. Basically, see your C1 and because nerve root of ulnar nerve is what T1 C1 to T8. So cranial nerve involvement when of the cranial nerve which are traveling through the inner foramen. So inner foramen from there vestibulocochlear nerve is also traveling. It will compress the cranial nerve, giving rise to this ulnar phenomena. So that is how it is happening. Directly, it is not. Directly, it is not affecting. Okay. When the inflammation of the vestibulocochlear nerve is there, then it is causing the compression of the cervical, basically that your cranial nerves that is again traveling through your cervical ganglion and traveling through your brachial plexus going up to the tip of the ulnar nerve. That is how it is happening. Okay, that is actually in detail. If you have read Ramsay-Hunt syndrome, those findings will be there. Okay. Now, Koplik spot, it is a enanthematous spot, not exanthematous spot. Now, site of latent viral reservoir, we have always discovered that is DRG. So, most of you have done very nicely. That is DRG. Dorsal root ganglion is basically the involvement of the nerve in cases of varicella zoster virus. Okay. So, most common dermatological involvement in herpes zoster. So, many people are you are writing trigeminal nerve. Trigeminal nerve is not the most common segment. Okay. Trigeminal nerve is the usually the second most common. So most common is thoracic, then will be on the cervicofacial. Okay, that is including both trigeminal nerve and other cervical nerves, then lumbosacral and then other segments. So most common segment which is involved is thoracic segment, and I have given you the PPT, so this is also mentioned in there. Then cervical carcinoma, most common causative agent. Very nicely you have all done correctly. That is HPV 16 and 18. So it is the most common agent of cervical carcinoma. So do read this topic because it is an important topic in your gynecology examination. Now plantar warts are caused by, so you have to know the types of the warts. So 16, 18, 31, 33, that is genital warts, and plantar warts, second and fourth wart are the most common warts are there. So I think the time is up. We have already discussed. I think next questions starting from questions onwards, we will discuss in the starting of the next class. It is very important to read the questions. Go, I give you all the PPTs, go in the home and read the PPTs. And finally, we will discuss the questions after finishing the test, because there is no point on just reading the questions writing and coming home and mugging up. Okay, so thanks very much for giving attention. I will send you the next class according to the MCI teaching schedule. Unfortunately, we are not able to take your clinical classes. I will next time I'll suggest you few topics on clinical classes. We can start with some video lectures or video demonstrations. I will try to start in the next class. Okay, in the starting of the next class, whatever the remaining questions were there, we will discuss so that at least you will be able to know what are the right and wrong questions. Okay, so thank you very much and have a good day.